So welcome everyone to the August LMA meeting, virtual meeting. And tonight we have the Sunshine Coast Health Report for 2020. And we've got representatives from the Sunshine Coast Hospital and Health Service, from the Primary Health Network, from Buderim Private Hospital and Ramsay Healthcare. But we're going to start off at the top of the list with our President, Roger Faint, starting off the meeting with a quick update. Over to you, Roger.
Thank you, Scott. This is the third year of the Sunshine Coast Health Report, and I envisage this annual event to continue into perpetuity. I would very much like to thank Chief Executive Adjunct Professor Naomi Dwyer for taking the time to join us. We all know how busy and important her role is, and it's very appreciated that she takes this event so seriously. To give you some perspective, Naomi is managing a medical business with an operating expenditure of about $1.3 billion. Would also like to thank her team, Doctors Marlene, Pearce and Michelle Johnston, the GP liaison officers, and Dr. Keat, Head of Infectious Diseases Department at SCU, and Dr. John Menzies and Karlyn Chettleburgh for updating members on various issues, including COVID. I would like to specifically mention the GPLOs for their remarkable contribution to assisting in breaking down the GP public hospital communication interface. I would also like to thank the PHN, particularly Chief Executive Patty Hudson, Dr. John Harper, Jodie Sargent and Jessie Barr for hosting this event. The LMA often collaborates with the PHN, and their energy and professionalism is obvious and very appreciated. For the first time, we have private hospital CEOs Karen Clark of Buderim Hospital and newly appointed Justin Greenwell of the Ramsay Group joining us. I would like to thank them for their time also. The concept of the health report is to inform and update members, public, private, specialists, GPs, doctors, young and old, of important issues relating to the provision of healthcare on the Sunshine Coast in a collaborative way. One of the ways of doing this is to break down communication barriers between the public and private sectors through a vehicle such as this one. The Sunshine Coast primarily provides clinical education for members in a social context. However, obviously there are medico-political issues that do arise, and the LMA is in a unique position to intervene, communicate and inform on behalf of members. That is why a strong, healthy working relationship with the Sunshine Coast Hospital and Health Service District, community organisations such as the PHN and the private hospitals is paramount. The LMA is intent on assisting members to give back to the community. For example, we now have a great working relationship with Wishlist, and through the wine donation of the Doctor's Dozen, sadly no cocktail party this year, we will have a major prize for their upcoming raffle. The donations include bottles of hard-to-get Henschke, Hill of Grace and Penfolds Grange with a total value of over $2,500 for 12 bottles. I encourage all to purchase tickets when the raffle opens later this year. We already know that partly because of COVID, telehealth is a very real and useful platform for providing healthcare in both public and private systems. I have many older patients who recently have had positive experiences with a telehealth call from SCU or their private specialist. The Sunshine Coast LMA is also using a digital platform for the benefit of its members and the Sunshine Coast community. Recently, we were able to use our Facebook page to find a replacement GP for 60 retirement village patients who had lost their original GP. Thank you, Scott Masters, tonight's MC, for running tonight's meeting, and the Sunshine Coast LMA Committee for their sage advice. Thank you.
Thanks very much there, Roger. So, Naomi, we invite you now to run your presentation.
Thank you, Scott and Roger, and thank you again for this great opportunity that you provide for all of us to come together as partners in healthcare provision within Sunshine Coast and Gympie. So tonight I thought it might be of interest to the membership for me to give a bit of an update about the year in review, and I've also brought along some of my good mates at Sunshine Coast Hospital and Health Service to profile some topics that again we hope you'll find really interesting. So I have Dr. Keat, who's our Director of Infectious Diseases and really has been quite an incredible clinical leader through our COVID response. Karlyn Chettleburgh, who is in her day job, is our Chief Operating Officer, but stepped into the role of Health Incident Controller and has really done an amazing job in relation to that. Dr. John Menzies, one of the issues that I'm sure we'll talk about tonight is the new normal and what are the implications of COVID in terms of our models of care, managing the demand and some of the waiting times that occurred when we necessarily had to cease some of the non-urgent care and the impact that had on many of our patients whose care was deferred. And as Roger said, our fabulous GPLOs, Marlene and Michelle, to talk about some of the really interesting and innovative initiatives that they're implementing with our GP partners. So that's a wrap up, and understanding at the end we're going to have an opportunity for questions. So we're really keen to hear your thoughts and questions on issues that we haven't covered through the presentation. So moving, thanks Jess, just in terms of full year 20, it's really, I think, hard to imagine when we started the year what was going to unfold, and I think really you know, unprecedented times in so many ways. If you look back to October, we had the dreadful bushfires in Sunshine Coast, and at that stage we were doing a disaster response in partnership with others, the recovery response that took us through to November again when we had the Tewantin fires where so many families were impacted. We didn't get much of a respite, I think, in the community. You remember it was late in December when the World Health Organization was talking about some cases of what they thought were pneumonia in Wuhan, and then in January when we had the first Australian case, and in February we stood up our emergency response. So I think, in terms of natural disasters, pandemic in a year, we've had really some very significant disruption to care delivery within the public health sector. But I think what has been interesting is that despite that, we've actually delivered record levels of care to the community. That's not to say that we still don't have some care to recover, but I think in terms of our year-on-year delivery of care to our community, great tribute to our clinicians that they've been able to deliver more. What I hear regularly from my team is what this year has really meant in terms of partnerships and, to really underscore, I think, what Roger has said, in times of crises, people coming together in very many ways with low walls for collaboration and partnership. And, Justin's online tonight, and we set up a new drive-through clinic at SCU, and Justin's partnership as a partner across the road at SCUF to be able to collaborate. And I think his response to our clinicians was, whatever it takes to actually keep our community safe, we're on board with that. But there are so many other different partnerships that have really, I think, been beautifully exemplified over the last 12 months. And then the new normal. So what does it mean for us as a major public healthcare organisation, and like the rest of you, I guess, in terms of maintaining that delivery of high quality care to our community, which doesn't go away. And in fact, I'm sure like us, you've seen where our patients and consumers in some respects have, opted to stay away from healthcare because they think it's the safe thing to do, and the rising morbidity that is associated with that in the community. And so really starting to plan and respond to this new normal, but also capitalising on some of the opportunities and innovations that came through. And for us, particularly, that's been in relation to virtual health and virtual healthcare delivery. So I think, looking back, it's possibly no wonder that some of us look a bit weary because it has been quite an extraordinary year. Thanks, Jess. So in terms of record levels of care to our community, you know, we have seen, despite the very significant drop that we saw in emergency presentations early in the year, that certainly recovered, and we've seen year-on-year growth in our emergency presentations, and also the rising acuity of those presentations. We're seeing more patients coming into hospital by ambulance. Our our surgical services team, I really think, have done quite an outstanding job. The level of surgery that they're delivering now is at record numbers in terms of not only the cases per sessions, but the number of sessions they're delivering. We've seen more outpatient care, and in fact, even when we were seriously impacted by COVID, because our clinicians shifted, we were doing nearly 50% of our outpatient care virtually, and during those times we actually managed to maintain some of the volumes of care, and so sustaining that into the future where that's safe and appropriate to do is something that defines the new normal that I know John will talk a little bit more about. We've also expanded our care delivery this year, both in terms of palliative care with our day clinic, the establishment of our eating disorders service, our rapid plastics clinic, the Gypsies expansion, which I know Michelle and Marlene will talk about, our Nurse Navigator program, which is really about wrapping effective coordinated care around people in the community living with chronic disease to keep them at home where that's safe and appropriate. And also our alternative models of care to hospital, such as our hospital in the home program, which we tripled, and has really been a very useful modality in the new COVID environment. In addition to more care, we've also seen some improvements in terms of the timeliness of care. Obviously, that is something that we focus on consistently to ensure that our patients are not waiting longer than clinically recommended times. And across a number of areas, our clinicians can be very proud of improvements, both in emergency department, where we either meet or within the tolerance zone for seen in time, for our most critically important outpatients, and again for our most acute elective surgery. So we always very focused on providing access, timely access to care, and responding to what you all see, as we certainly do, the rising demand for healthcare with our growing population. Thanks, Jess. So just to touch on COVID, and I'll just speak at a very high level because Keat is going to provide the clinical expertise, and Karlyn will share with you some of the significant planning and preparation that we did that really has persisted since early in the year, when we think that we were asked to prepare to triple our emergency department capacity and double our ICU capacity. And so we're able to do that through our COVID preparedness. Flattening the curve became part of the new vernacular for all of us, which was really about finding, testing and isolating persons who were suspected of having COVID or were COVID positive. And so very busy. Our public health team, who often are the quiet achievers in the organisation, really proved the criticality of their response. And so to give you an example, in our public health team, I think we started off with 3 contact tracers, and that team swelled to nearly 120 in the peak of our response. And then, of course, isolating those who are, vital to avoid community transmission. And as we've seen through our numbers, the community have really done a brilliant job of observing all of the requirements. And I'm sure Keat will share most of the cases that we've had within our region have been overseas acquired or interstate acquired, and we haven't had community transmission for some time. So I think collectively, as a community of healthcare providers, I think we managed the first wave very well. We were very fortunate we had so few hospitalisations, and did not have the level of acuity, the dreadful acuity that we've seen elsewhere. As you know, with the federal government making decisions and the state government making decisions about the need to really turn and face the preparedness, given the expectation of the modelling of the number of people who'd be hospitalised, the number of people who would require ICU, and even the early modelling on morbidity. There were some very early decisions made around cancelling activity that was not urgent. And with that, it meant that we cancelled elective surgery, we cancelled outpatients other than for urgent, we stopped our breast screening, we ceased oral health, and so that obviously had a significant impact on waiting times for people who were accessing care. And then when those restrictions eased, and this is where our partnerships with our private hospital friends really became very beneficial, and being able to provide care, increased levels of care to enable our patients to receive time within clinically recommended cases. The new normal, again, is for us is maintaining our business as usual, if you like, but also having an eye constantly to the potentiality of a cluster outbreak. Now, whether that's a very cautious residential aged care facilities, and I'm sure probably aware that we've got, I think, about 50 on the Sunshine Coast residential aged care facilities. One of those is ours. We've got a high volume of residential aged care beds and consumers who have that vulnerability in relation to COVID. So that new normal of being able to ramp up our fever clinics, being able to provide drive-through clinics, the virtual clinic that we have. We've been well supported by our primary healthcare network, who have stood up some of the federal respiratory clinics, obviously what our GP partners are doing. So all of that has really been, I think, very significant in terms of this community's ability to manage the COVID response so effectively. Partnerships and engagement, I think, again, just to really emphasise what the health community in the region have done in partnership with our community. I think we have had one death in our region, and our cases have recovered, but Keat will talk more about that. Like you, the issue of wellbeing and resilience, so the wellbeing and resilience within our own workforce. We were just talking before the start of tonight's session, about the level of absenteeism, because all of our organisations, our people are representative of the wider community, and the message is very clearly, as it should be from the Chief Health Officer, about the low threshold. If people are unwell, to stay home, and this is how we will combat, further clusters and community transition. But we're also seeing, as no doubt you are within our community, the sequelae of COVID in terms of psychological distress, and we are certainly focusing in terms of resilience and recovery in terms of our touch points with community, as I know you will be. So thanks, Jess. I'll go on to, so some of the other things besides COVID and responding to some of the natural disasters and maintaining care. We've also been working very hard in introducing new systems to improve both our clinical and our corporate performance. And so we were very proud, and I know Michelle will talk a little bit more about this, but we're very proud to lead the state to be the pilot for rolling out GP smart referrals. What you may not know is that 80% of general practices in our region are on smart referrals. So we lead the state in relation to that level of participation in GP smart referrals. So thank you to all of our general practice partners. But Queensland also leads Australia. So we lead Queensland and Queensland leads Australia. That means that we are a leader in Australia in terms of this important modality between us and GPs. We're looking at further opportunities to explore how we can use some of the benefits of digital technology, not only to support general practitioners, but also looking at, for example, patient portals, so they can come in and look at their appointments and manage their appointments. So again, opportunities for that. I'm sure this won't be, this may not be of much significance to all of you, but for those of you who have implemented a major enterprise new financial system and HR system, very disruptive alongside and certainly impacts our clinicians, but was delivered successfully in what's been a very busy year. And of course, it's been our first full year of the integrated electronic medical record. You remember that at the time that we went live last, just prior to the start of the new year, we were the largest full stack rollout of an integrated electronic medical record in Australia. I was starting to see, there's my energy management, I'll just turn my lights back on, and starting to seeing the benefits of that that we had anticipated in terms of improvements in safe care. Thanks, Jess. Thanks, Ange. In terms of our people, and we are certainly very proud of our team, and if I can just spend a short minute just to be a proud CEO to brag about some of our teams. Our plastics and reconstructive team won the Premier's Excellence Award, and this was for their very innovative model of care called the Rapid Clinic, to provide more timely care to patients requiring some plastics treatment. Some of you will remember the issue we had a few years ago where the AOA withdrew our accreditation for orthopaedic training. So we were very excited when we were re-accredited with another 4 years. We're very committed in our organisation to choosing wisely, and that we have a fantastic faculty, both with clinician leaders and consumer leaders, and for them to receive national recognition in terms of the work that they're doing made us very proud. Our junior doctors and the culture within our junior doctors and their level of satisfaction is a great barometer of culture, and so to see such strong improvement in the AMA Junior Doctor Survey also made us very proud. We are the most oversubscribed hospital for interns, and our Griffith University Medical Program, which I know the SCLMA were such a strong advocate for many years before that occurred in terms of having our own medical school. We'll be very proud to see that going from strength to strength. We've got a full complement of students. We are oversubscribed. These young students want to come to the Sunshine Coast Griffith University Medical School. All of the students pass their exams, which I think is a tribute not only to Griffith University, but the very fine teachers that they have from our own medical and other staff, clinical staff, within the interprofessional learning context. Our research, we have over 300 clinical trials in a variety of areas. We've got some really exceptional researchers. We're also investing further in offering PhD scholarships and research grants to pump prime some of the great research talent that we have within our health service. Thanks, Jess. In terms of planning for our future, so I've talked a lot about some of the highlights of 2020. One of the great outcomes, some of you would be aware that we've had an arrangement with Ramsay and the Noosa Hospital, which was part of an historical 25-year arrangement. And we were very proud to announce that we had negotiated with our partners in Ramsay for a further agreement for them to provide both public and private care to the community of Noosa and surrounds, and that's been a very valued and important partnership for us in that community. We're also doing some work which we expect to finalise by the end of the year, which is our 10-year Master Clinical Services Plan, and that in effect will take account of the very significant demographic shifts that we're seeing in the community, very bimodal with all of the significant developments in the south, which is creating significant demand in terms of young families. the serious aging of the population as well, and looking at healthcare needs of our community over the longer term, and how we can best plan our services, from Malene, Gympie, Nambour, Caloundra, SCU. I hope I haven't left out one of my children. But in terms of looking at what services we provide where, at what level of complexity, as an interdependent health service for our community over the next 10 years. We've also have previously announced Nambour redevelopment, and there's been a lot of activity on that front. There's been some demolition work, recognising that this will be a brownfield site, because we'll be redeveloping Nambour while it's a functioning hospital, which always creates significant complexity and requires very astute logistical management. We've had a little bit of a delay there, but we think that we should be able to manage that back down to complete the Nambour redevelopment, which will take it back up to a 250-bed hospital in 22-23. But as you'd appreciate, with the impact on the construction industry and some of the slowdown, that's had some ripple effect to us, but we hope to be able to claw some of that back. We also are now doing the SCU stage 3, which again will take the physical capacity of SCU up to that final envisaged capacity. And then we have Sunshine Coast Health Institute, which is our research and education hub, if you like, with University of Sunshine Coast, Griffith University and Queensland TAFE, and strategising with those partners about the long-term education and research profile that characterises a university health service. So there's a lot of work also, as you can see, happening about meeting the healthcare needs for the future. So looking ahead in terms of what's on our mind, certainly as we've started a new financial year, managing increasing demand is a significant issue for us, and the clinical reform that we need to do to be sustainable over the longer term. And one of the key strategies in relation to that is, particularly through our partnership with the primary healthcare network, looking at much stronger integrated care to manage that growing demand in the community. I mentioned the 10-year master service plan, the agility of our COVID response with BAU, wellbeing and resilience of our people. We have just refreshed our consumer and community engagement strategy and group of consumers. We have a very active group who are representative of the many different communities across our region to ensure that we're responsive to the needs of them. We will have next year our major organisational wide accreditation, which really is an attestation of the safety and quality of care that we deliver every day. We continue to work very closely with our community to close the gap in health inequality we see in our Aboriginal and Torres Strait Islander community in the region, and certainly in terms of the fiscal impact of COVID, has not escaped any organisation within Australia, within Queensland, and certainly within Queensland government. You may have seen the Treasurer announce the $3 billion debt and savings plan, which is again a consequence of this significant and deleterious financial impact across systems and both public and private sector that will impact us for many years to come. So I think that that is hopefully of interest to you in terms of the year in review at a high level. And I'd now like to welcome Keat to provide a clinical perspective of COVID for you.
Thank you, Naomi. So next slide. So I guess one of the big things I've noticed about COVID is that, it's constantly changing, and I think it's important that, as a healthcare system and as a community, we don't become complacent. So, for example, I submitted these slides, I think, on Friday night or Saturday morning, and then by Sunday, a lot of my things were up out out of date, and there's been a lot of things happening this week. So just to start with, I guess, what we've seen around in terms of epidemiology. So worldwide, there's been nearly 25 million, 24 million cases. In Australia, we've had about now, as of yesterday, 25,000 cases and 1,100 cases in Queensland. And as you can see, just on the little bar graph in the middle of the page, we have all seen what our colleagues in New South Wales and Victoria have been dealing with. You know, we've had a rise of cases with our so-called second wave, particularly in Victoria, but also New South Wales, which has led to a number of public health measures that have been implemented in Queensland. Testing is just testing is very important, and we've done over 5.5 million tests in Australia, and about 0.4% are positive. And so just to put that in perspective, I just was watching a talk this afternoon from someone in America, and their testing percentage positivity is around I think it's around 6 to 8%. Next slide. So just in particular with our own health service in our own district, we're now at 99 cases, and I did have this on Friday. The last case that we had was on the 18th of July. However, we did have 2 new cases admitted on the weekend after I did this slide. And so, I guess this just shows that, when we think that things are going okay, we need to be prepared for the worst. We've had, as we know, as we've all seen, we've had new clusters or new cluster recently in Metro South and West Moreton. And that this week has led to a number of significant changes to the public health advice. So the Chief Health Officer recommended new changes or new restrictions on social gatherings, both in Brisbane and around Queensland. But there's been significant impacts onto visitors in hospitals and residential aged care facilities in the Greater Brisbane region. The other big thing that's happened this week has been a recommendation of increased use of PPE in Brisbane hospitals, and in particular Ipswich Hospital. Naomi mentioned before that, so just back on that, if we just go back to the previous slide, that most of our cases in our district have been overseas acquired, and that still remains the case. We've had 1 death that has been attributed to our health service, but that person was someone who had travelled interstate. Most of the patients that we've had in our health service have been managed in the community with our virtual isolation ward, which was set up very early on, so we could manage well patients in the community without having to admit them. We've had 1 patient who's been admitted to ICU that didn't require intubation. Next slide, please. So just a few things on treatment. I think this is something that's changed very rapidly over the time, and I think there's still lots of trials happening. We're learning lots of things. So early on in the pandemic, it was all about hydroxychloroquine and Keat, and really both of those treatments have fallen by the wayside, and there's been increasing studies showing that they are not as effective as we initially thought. Remdesivir has been the most recent success in terms of trials that have been published, and so this is an antiviral which has been shown in randomized controlled trials to improve outcomes, particularly in patients who are on oxygen but not requiring ventilation. One issue with remdesivir has been the international supply, and because of obviously the large number of cases around the world, the supply that we've had in Australia has been very limited. Supply in Australia is done through a national stockpile, so you have to apply for it centrally to the government, who then approves it, and there's quite strict criterion on who can get remdesivir. Dexamethasone has been the other well-publicised treatment that's been proven to have some efficacy, particularly in those who require ventilation. And the way I kind of think about it is the antivirals were more likely to work early on, where dexamethasone, which has obviously the anti-inflammatory effect, has potentially more use in the latter part of the illness when there's a lot more inflammatory problems. There are a number of other possible treatment options that are being studied. So in Australia, the main study that is occurring in terms of COVID is the ASCOT trial, which we are part of. And initially, the ASCOT trial was hydroxychloroquine and Keat, and that arm is now being ceased because of the increasing evidence of its inefficacy. The only arm that we have at the moment is convalescent plasma, which we're sorting out our ethics to try to be involved in that arm. It is likely that the Ascot team will put other arms onto that trial, so we can enroll patients onto these arms for treatment. Next slide. So I guess the other big thing that has always been very interested in is the vaccine. So most of the vaccines work against the spike protein, which was on Naomi's slide and my previous slide, which is those little red spiky bits on the end of on the outside of the coronavirus. There's around 167 vaccines in development and about 27 in human trials. There's a mix of different types of vaccines, from live vaccines to live inactivated vaccines, recombinant protein vaccines, vector-based vaccines, mRNA and plasmid vaccines. There are a number of vaccine candidates that are in phase 3 trials, and I guess the one that's been mostly well publicized has been the Oxford vaccine, which is an adenovirus carried vaccine. But there's a few others around, including, and we've all heard the news about the Russians who have started using their vaccine, and there's also one from China that's been used. Next slide. So just in specific to Australia, we've got a number of clinical trials happening. The USC is involved with clinical trials with the Novavax vaccine, which is run by the Nucleus Network, of which there's which is in Brisbane as well as Melbourne. And the Nucleus Network is also running clinical trials on the University of Queensland vaccine. But there are there's 2 other vaccine trials. You know, it's certainly uncertain when we are going to get a vaccine. There's some discussions that there may be vaccines in early 2021, but I guess we also don't really know what the efficacy of the vaccine is going to be, and also how long, and how long it's going to last. We certainly know from antibody studies that people's antibodies certainly decrease significantly after at around the 3-month mark. So I guess that's a quick update on where we are with COVID-19, and I think we're taking questions at the end.
Thanks, Keat. Now I'd like to introduce Karlyn Chettleburgh, who's also our Health Incident Controller, and Keat.
Good evening. Next slide, please. I'm just to the right of your screen. I think a lot of people have got their cameras on, so you won't be able to see all of me, but I am completely here. So just in terms of our COVID preparedness, I just wanted to start by saying that I won't be repetitive with the issues that Naomi has already covered in her introduction, but I will just go into a little bit more detail with some of the issues. So to begin with, that in early January, the Chief Health Officer made some announcements in relation to what she considered to be a pending pandemic. At the time, many of us thought that this seemed to be a very extreme response. However, it very quickly became evident that the Chief Health Officer's early concerns were borne out. That Sunshine Coast HHS, their incident management team, went to lean forward in late January, and then when we had our first case admitted to hospital, which was in late February, we then went to stand up. And since then, we've been in stand up phase right until now. So what that means is that we meet every day, except for the weekends, and we also participate in the State Health Emergency Coordination Centre daily teleconferences, which are 7 days a week. The first tiered 1 to 3 responses, that we had to very quickly develop plans in relation to each of those phases, and part of that planning was to identify the criteria and the triggers that would activate the next tiered level that we needed to respond to. Initially, we thought that we would only have to have tier 1 to 3 plans. However, that it became evident that with the overseas or international experience, that we would have to have a much more clearer response in relation to a catastrophic event where we had individuals who required hospitalisation and ICU requirements that far outstripped not only our local HHS resources, but also Queensland health resources more broadly. So that introduced Tier 4 and 5 plans, which had to be put in place. The Tier 5 plans are statewide plans, which we contributed to, but certainly for our HHS, we have Tier 4 plans, which ensure that we've got a COVID specific hospital, which for us would be Sunshine Coast University Hospital, and all of our other hospitals would be support hospitals where we would send patients who were not COVID positive. As part of our tiered planning, that we also identified that we needed to stand up fever clinics, and our first fever clinic was at Caloundra. Very quickly it was identified that having a drive-through fever clinic would actually be more efficient. It would reduce the call on PPE, and also for patients attending the fever clinic, they felt more comfortable because they didn't have to leave their cars and have contact with other people during the testing phase. So we established the first drive-through fever clinic at Caloundra, and that was in March. Subsequently, as Naomi said, we now have 3 drive-through fever clinics. The most recent is at P2 car park in partnership with Exemplar Health and with Scuff. And we also have a drive-through fever clinic at Gympie Hospital. We have 1 walk-in fever clinic which remains at Nambour General Hospital. Our PP&E in the beginning was something that we were very concerned about, and the concern was related to the supply chain. Most of the PP&E in Australia came from overseas, from Europe and also from Asia. As a consequence of what was happening in those countries, that the supply chain was greatly impacted, and so orders were not delivered on time, and also some of the orders they delivered products that weren't actually consistent with what had been ordered, which created much concern for our clinicians. We were very fortunate that we established very quickly a PPE working group led by Dr. Owen Evans, who is our Clinical Director for Surgical Services, and we began identifying alternate supplies. And it wasn't just for PPE, it was also for our antiseptic wash what would normally we'd use was Cutan, and the Cutan supply was at a critical level, and so we negotiated with a local distillery for them to actually develop alcohol rub for us, and that we still, and in fact you can see here behind me one of our containers of alcohol rub, which we use in non-clinical areas so that we can preserve our Cutan for our clinical areas. We're much happier now that our PPE supply chain is much more stable, that as you would have heard, that the state has stockpiled PP&E. However, that we're also very conscious that with the emerging issues over the last week and the significant increase in use of PPE, we still have to ensure that our stewardship is very tight and very clear in relation to our use and our supplies. So we monitor that on a twice weekly basis, and also monitor it looking at what our current utilisation of each of the items are. One of the other things that we're able to organise for local supplies to provide were face shields, and face shields are very helpful in terms of being able to use perhaps level 1 or level 2 masks with a face shield, which gives you the equivalent of a level 3 mask, and the level 3 masks were the ones that were in much shorter supply. As Naomi said, that we're required to double our ICU capacity and triple our ED capacity. We were able to have plans in place to achieve that, and in fact we were able to triple our ICU capacity, and we're very fortunate because we're a new build here at Choong that we have the up to 50 ventilators to manage ventilated patients. As Naomi also touched on, early identification, isolating and testing is one of the cornerstones of managing or getting on top of an outbreak. And contact tracing and our public health unit were really at the core of our response during this pandemic. They undertook a significant amount of contact tracing, and as Naomi said, we went from having 8 contact tracers within the public health unit up to 120 at the peak. We still have all of those staff trained, but they've now gone back to their normal roles, and I'll talk a little bit more about how we're able to train so many people and have so many available. But what that meant was, with those volumes, we could actually provide a 7-day-a-week extended hours into the evening service so that we could saturate the contact tracing when we identified positive cases. The ceasing of Category 3 referrals for outpatients and elective surgery, that was really how we were able to release resources to be able to provide the responses for our fever clinic resourcing, and also for our contact tracing and support of the public health unit. That obviously had an impact on our capacity to meet the needs of our community, and we now know that, that there are a number of people who have had delays in their treatment. We have received funding for what's been called a planned care recovery program. So we're in the process of developing our plans for how we're going to ensure that those people who had delayed treatment associated with the COVID pandemic, that we're able to provide them now with more timely treatment and fast track their surgery and their outpatient appointments. Residential aged care facilities have been a significant focus from the very beginning, and continue to be a significant focus. That if you remember that we did have in Queensland an episode at Rockhampton where a nurse tested positive in an RACF, that resulted in what was called a rapid response team going to Rockhampton, and it was staffed from throughout the rest of the state. So each HHS is required to have a rapid response plan, and often that's coordinated where there is an outbreak within a vulnerable community, such as an RACF, or within the Aboriginal and Torres Strait Islander community, that each HHS contributes resources to be able to provide a rapid response to replace staff on shift, but also to undertake fever clinic testing and working rostered shifts. Our workforce, one of the issues that we had was trying to balance the safety of our workforce, responding to the messages about if you don't need to leave your home, stay at home, whilst also having to provide a 24-hour-a-day, 7-day-a-week health service, which was considered to be an essential service. So we developed a very comprehensive program where we were able to assess each of our staff on a case-by-case basis, looking at whether or not they fell within a vulnerable group, and whether or not we were able to provide social distancing measures within their workplace, and whether or not it was appropriate for their role to be able to work from home. That we had at one point 300 staff working from home, and given that the size of our workforce, that wasn't a huge number, and so I think that that was testament to the stamina and resilience of our workforce, that so many stayed on the job, and that we were also able to provide them with safe working conditions through managing our workplaces and social distancing. The other thing just to mention is how important it was for us to work very closely with the LDMG and the DDMG. So that's the Local Disaster Management Group and the District Disaster Management Group. Those two groups are headed by Queensland Police Service and are made up by representatives of QPS, QAS, QFES, and councils, and ourselves in the Department of Communities. So that collaboration is incredibly important in managing any disaster. Even though health was obviously the lead agency for a pandemic, that we can't actually do it all without the support of those other organisations. With our workforce, we also obviously had to prepare for the fact that up to 30% of our workforce may be off sick with the pandemic, and so that was another major part of our planning, was in how we would actually be able to resource areas if we did have 30% of our staff off sick. So just some quick facts. We had 99 COVID cases on the Sunshine Coast. We've just had 2 additional cases, which are crew members from a tanker that was off the coast of Mackay. We only had 1 patient who was admitted to ICU during this period, and they were not ventilated. We have reviewed 50 RACF COVID safe plans. To date, that we have seen over 34,000 presentations to the public fever clinics, and between the public and private pathology providers, that we have tested 55,407 individuals on the Sunshine Coast. As at 24th of August, we had 38 people in hotel quarantine, but we're now expecting to receive international travellers returning from overseas, because the Gold Coast and the Brisbane hotel accommodation has reached saturation point, and so they're starting to divert overseas travellers to the Sunshine Coast hotel accommodation or quarantine accommodation. And this afternoon we're expected to receive an additional 83 arriving on the Sunshine Coast, and we can expect those numbers to grow over the coming days and weeks. That in support of other jurisdictions and services, we've deployed staff to Rockhampton for the residential aged care facility issue, that we sent nurses to Victoria. We had contact tracers providing a virtual contact tracing service to Victoria, and more recently we have had a member of our team go as part of an AUSMAT team to Papua New Guinea. So that's all for me, and I'll hand over to Dr. Menzies.
Thanks, Karlyn. I've only got 2 slides. I can go on to the next one, just to give you some information about what's been happening with outpatients. On the clinical side, where we've seen a significant change has been in how we have helped patients during this time of social distancing, when they not only had to socially distance, but we've had the community being very concerned, particularly in the early phase of coming to a hospital, where they may have feared that they could have caught the COVID infection. So we actually saw a significant shift in the way that we delivered a lot of our outpatient services. The percentage of remote outpatient consultations, either by telephone or by tele-video conferencing, or what we call telehealth, increased significantly, and the utilisation averaged over 43% for all services from the period, or during the period March to June. And this represented an increase, as you can see on the slide, of about 25% from pre-COVID levels. Over the last couple of months, obviously, the presentations in person have increased, but we're trying to maintain the telemedicine numbers at high levels for a number of reasons. One, it helps us to keep patients close in their own community, close to their own home, and also it can be quicker and more appropriate for many patients to have that type of assessment. It's not suitable for everybody, which we know, but it's a great assistance to a lot of patients, particularly those at furthest parts of our district, particularly around, say, Tinkham Bay. On the next slide, we can go. Just want to mention that we obviously have ramped up dramatically, just like most general practitioners and clinicians in private practice, the use of Microsoft Teams. We've provided training for GPs in using that, and I also acknowledge the work done by the PHN, which also provided a lot of training for GPs as well in using Zoom and other types of technology to interlink with patients. In terms of outpatient recovery, rebooking and rescheduling of Category 2 and 3 patients, they were the categories that saw the greatest impact. The number of Cat 3 referrals on the wait list decreased from 18,000 in May to 16,700 as of June 30. But since then, the numbers have changed again. And in the presentation that's to follow from our GP liaison officers, they'll actually give you an update on where we currently sit. Just want to finish with two things. The easing of restrictions and recommendations of acceptance of Cat 3 referrals saw a 55% increase between May and June, which was quite staggering, but to be expected after we had that significant drop-off in late March and April. The reinstatement process of referrals was started in July and continued throughout August. And you'll hear in the next presentation some of the more interesting innovations that we're trying to put in place to help both speed up referrals from GPs and also to try and keep patients back in the community rather than having to come to the major hospitals for their specialist appointments. So there's some quite innovative things happening, and I'll now hand over to Elena and Michelle to talk about some of those interesting advances.
All right, thanks, John. So if we can go to the next slide. So my name is Marlene Pearce, and Michelle Johnson is my fellow GP liaison officer presenting tonight. We also have Dr. Edwin Cruz in our team. The three of us share the role of GP liaison officer at the Sunshine Coast Hospital and Health Service, and between us, we are all three of us practicing GPs on the Sunshine Coast as well. So we enjoy our time thoroughly at SCU, and we enjoy our time in our general practice settings as well. And it helps us help you to be across both sides of this coin. So we'll go to the next slide, thanks. I just wanted to give our website a quick plug because for if any of you haven't seen it before, it's gone live in the last year, but there's some very helpful quick links to some of the more common things general practitioners might be looking for. And if you can't remember where to find something, if you type SCHHS, Sunshine Coast Hospital and Health Service, GPLO into Google, you'll find our website pops up quite easily. And on here, there's information about referrals, there's information about Healthpathways, there's information about fracture clinics, GP shared care, and the health provider portal. So lots of useful links on there, as well as some explanations if you have no idea what some of those acronyms mean that I was just talking about. All right, so next slide, thanks. Okay, so in the telehealth and COVID era, moving forward on our digital enhancements and digital improvements is very high on the agenda. In particular, our mutual desire to phase out the fax. And I say mutual because both general practice logistics and hospital and health service logistics are still in some ways wedded to the fax, and we are, I assume, all motivated to move to a much more digitally savvy future. So particularly in the last year, we have had a very significant internal focus on that, and GP liaison officers, our patient safety teams and our executive leaders have been working closely with medical records, aka clinical information services, and some of our IT experts to really pick apart our communication outwards towards the community, towards general practice, to make sure that our methods are very stringent in our quality assurance, and to go through who is getting faxes and who is getting digital communication, and making sure that those GPs who did want to get digital communication were receiving it. This led us to some really interesting audits that have taken place, and I'll shortly show you the statistics, but it's been a significant piece of work to tidy up I guess the mailing room, if you like, and it's been as complex and involved as our team actually contacting a few clinics who are having some fax issues, going out to talk to the practice managers and actually troubleshoot at whose end the faxing issues were occurring. So it's been quite a broad piece of work. And if we go to the next slide, I'll show you the stats. So as a result of the audit and the improvements that we've been doing, March this year, that is the number of outgoing pieces of correspondence in blue that were digital. In July, you can see there's a much greater proportion of outgoing communications that's digital compared with fax. Now, we know that we're still probably not quite capturing all practices who are keen on receiving digital communication, and so please, if you're out there listening to this talk and you'd like us to help resolve any technical issues you may be having, please contact the GP liaison officer and we can help improve that for you and help your practice troubleshoot if you're having issues. All right, next slide. Another piece of digital improvement that I'm personally very excited about, our transcription software that our clinicians, our doctors use to write their outpatient letters will soon be able to upload those letters digitally onto the health provider portal, also known as the viewer if you're using it from inside the hospital, or if you're using it from general practice land, it's the health provider portal. So this is the platform that Queensland Health holds all the patient information in that GPs can log into from their desktop computer in their clinic rooms. And as you can imagine, it will be hugely beneficial to have outpatient letters up live on there, so that if you are seeing a patient and you need to refer to an outpatient letter that you personally don't have a copy of, you won't need to write into medical records to get a copy of it. They will all be there. Hopefully from September, October, that should be going live. So I think that's a big improvement and will really improve the quality of information available to general practitioners. I should point out that that does not replace the GP personally who's looking after that patient personally receiving a copy as a piece of clinical handover when they're expecting to get that letter. That will still occur. This is more that this outpatient letter is going to the digital library for yourself or anyone else to look at into the future. So it will really complement also the direct clinical handover that occurs. If you aren't using Health Provider Portal, or if you've not used it for a year or two and you want to check back in because it has much better functionality now than it used to, there's a link down on this slide that you can follow, or you can also follow the links on our GPLO website. All right, next slide, thanks. Okay, so this was some interesting statistics. I went to our referral centre and I thought those of you in the community who have had, you and your patients have been affected by the Cat3 deferred referrals. I thought it would be interesting to point out that during that window where there were deferred referrals for Cat3, only 1,120 were not accepted at our site, as opposed to over that total period, 13,133 were received. So I wanted to share that there was a very significant amount of work still going on with the more urgent care going on at the hospital. But for interest's sake, those that were deferred belong to predominantly orthopaedics, ENT, gynecology and general surgery. Now, one important piece of information is that we are hopeful that all of those have now been acted upon and resolved. And I wanted to make this very clear to any of the GPs listening tonight. Either those deferred referrals that you sent in will have been reinstated from the date of July 1st as per the Director General's instructions, or the patient may have been contacted and they said that they no longer required the appointment, or some specialties actually spoke directly with the GPs and offered direct consultant advice for the problem instead of requiring an appointment. So if you as a practitioner believe that you have a patient who was affected by those deferred referrals and you haven't heard of a replacement plan for them, please can you let the referral centre know on the GP hotline, because they want to correct all of that and get care back on track for our patients. All right, so I'm going to hand over now to Michelle Johnson, my fellow GP liaison officer, who's doing the next slides.
Thanks, Marlene. Now, just before I go onto this slide, to follow on from what Marlene said a minute ago, our specialty teams have been working very hard. In fact, could we just go back one slide, please? I want to do the last dot point there. The last dot point, with GPs offering consultant advice or getting consultant advice in lieu of an appointment, I think that's a really important thing to bring to the fore for you, because one of the silver linings of COVID-19 has been the opportunity to develop new collaborative models of care. And we're very excited about this. So the specialty teams have been working really hard to figure out which patients are appropriate to receive advice only from the consultants, which will basically prevent them from sitting on the end of a waiting list for potentially a long period of time. So we are working really hard to try and develop models that will allow that to continue into the future. Sorry, move forward to the next one now. Next slide. Okay, resources for GPs. So Sunshine Coast Healthpathways, I'm sure you're all very well aware of that page. There is the COVID-19 page with a lot of really useful information on there, fever clinics, local resources, other information. I'll keep going to the next slide. I know we're a bit short on time. So with the next slide, this talks about specialty advice again for GPs during COVID. If there's a delay to your patient receiving care, or even into the future, we've actually found some consultants in each specialty that have given us a contact number where GPs can actually phone them and get that advice over the phone to allow them to provide better care to their patients in the community. There's also some really exciting support lines there, the palliative care state support line, which you can click on the link there or Google PAL Consult, and also the National GP Psychiatry support line, which is also a fantastic resource. All of these really were developed to give GPs more support to look after patients when they may not have access to consultant appointments in the hospital. And I think we're learning a lot from that in how we can really use this into the future to allow patients to be managed in the community. Next slide, please. Okay, so 2 years ago, I came and spoke to you about our new project, which was GPs with special interests working in the hospital, and I'm really pleased to tell you that now they've become a valued part of our specialty teams, quite established in their roles. And our team constantly have specialists coming to us and saying, can we have a gypsy? So it really has been going very well. We've had great feedback from patients, from consultants, and from the gypsies themselves that have found it really valuable. The learning that they receive, as well as the advice and the GP perspective they can give to the hospital teams. So we're actually currently looking for more gypsies, and contact us if you know of any GPs that are interested in these roles. Next slide, I think, is the end. Yes, so don't ask questions now, but use that little chat box at the bottom right there and put your questions in for the end of the evening. Thank you.
Thanks, Michelle, and we'd like to welcome Dr. John Harper now from the PHN. Thank you to the Sunshine Coast Hospital and Health Services team for your excellent presentations. Over to you, John.
Thanks, Scott. So I'm just going to quickly run through just some updates from the PHN perspective. I also work as a GP liaison officer, but with the PHN, and work closely with the GPLOs at the hospital end. So I'm just going to run through a quick update on Healthpathways, smart referrals, and the psychiatry advice line. So Healthpathways, which is, can you believe, nearly 4 years old, so launched back in 2016. It's now really quite complete. The vast majority of the pages are now complete with localized content, and of course none of this would have been possible without some fantastic enthusiastic collaboration with some local public hospital specialists as well as private specialists, which has worked really well. As you can see, it's dead easy to get onto Healthpathways. If you've not seen it before, you just Google Sunshine Coast Healthpathways and it'll pop up, and then everyone's got the same login credentials. So it's just username is user SC, password PWSC, It's designed principally for GP users, but we know that there's a lot of registrars in hospital training, as well as specialists in public and private hospitals, as well as allied health in hospital and community providers that are also using it as well. It's very much for health professionals. It's not really a public-facing website, which is why we have the login. It's now a mobile-friendly site, so if you've not looked at it for a while, just go on to the next slide. You can see that you can look at Healthpathways on your phone, on your iPad, on the computer, and it all looks and works very nicely on that. We've got a whole stack of pages on COVID-19, which have been developed in collaboration with Queensland Health and the state response team for that. And those pathways are updated on a regular basis. So whenever there are significant changes to testing criteria, hotspot location, treatments, all that sort of stuff, then these pages get updated. They have been designed and supported by Queensland Health to be the source of truth for management of COVID-19 in Queensland, which has been great. Just go on to the next page. We have a number of sort of new and helpful pages worth a look at. So these are some new ones, one on chronic kidney disease, polycystic ovarian syndrome, the new changes to the pneumococcal vaccination, which are a little bit of a change from what we were doing previously. So it felt we needed to create a bit of a page for that. So there's a very easy to follow page on Healthpathways about pneumococcal vaccination as well. And yeah, we've got the things that often come up, when to refer for bowel cancer screening, how often should people have colonoscopies for polyp surveillance, those sorts of things, when to follow up ultrasounds for ovarian cysts, all that sort of stuff, which is quite hard to remember as a GP and seems to be constantly changing. Healthpathways is really useful just to jog your memory on things like that. Next page. So smart referrals. It's been a bit of a rocky road, is the image there. We launched on the Sunshine Coast in April last year, and we were the lead for Queensland. So we have got an incredibly enthusiastic group of GPs on the coast, and they've done amazingly well at adopting smart referrals. And as Naomi said, we managed to roll it out to the vast majority of practices. As all technology, sort of new technology things, there were some bumps along the way, but many of those bumps have now been ironed out, and the GP smart referral product is sort of improving with every upgrade. The PHN, we're really keen to get back out on the road to support GPs who may have tried smart referrals once or twice and need a bit of a refresher. Obviously, COVID restrictions notwithstanding, we're trying to organise more visits out to general practice so we can do some more training on that. And please do contact the PHN if you would like a bit of a refresher or training on using smart referrals. The main advantages of using the smart referral system are that you have the referral criteria for referring into public outpatients is already embedded within the referral program, which means you don't have to refer to a different website like Healthpathways or the CPC website. But if you just follow the form, then you should be prompted for all the information that you need. The other major advantage, if you just click to the next slide, is that you can attach things to a smart referral, which you can't do with a regular e-referral. So this is really helpful if you've got a scanned-in report in a PDF format. You've got an ECG. Many of the referral criteria do require some reports or ECGs, and you can attach these to the smart referral. And of course, you can attach JPEGs, so photos, images, which is really helpful for referring into things like the dermatology clinic, telederm service, and also to the rapid access plastics clinic as well. Thanks. And then lastly, just The PHN has funded the GP support line for GP, so it's a psychiatry support line. Essentially, it's designed for asking for advice of those sort of non-acute situations where you might need to ask what medications you might want to swap over to, or how you might do that, maybe from diagnostic clarification, things like that. We've got some fantastic psychiatrists on the coast, many who we can get hold of on the phone and have a quick chat to. But as we know, sometimes it's not always easy to get hold of a psychiatrist for a quick bit of advice. And so this support line is designed to do that. You just have to register, and your practice manager can do a bulk registration on the website. And then once you're registered, then you just call the 1-800 number anytime. And I think about 80–90% of calls are picked up straight away, and the others are you get a call back within a couple of hours. So it's pretty good. And that was it. That was an update from me. Thanks.
Thanks very much for that, John. And we'll now go straight across to the General Manager of the Private Hospital, Karlyn Clark, for an update on service.
Thanks, Scott, and thanks, Roger, for inviting me to just talk briefly tonight. Obviously, I'm not going to go into everything that we've done with COVID-19, because I think Naomi and Karlyn spoke about how challenging it was. I'd say the difference for the private sector was the shock that the government came out with the direction that we couldn't perform elective work. So that potentially will cause a lot of stress and distress for patients who were already booked in, but it was something we had to do to be able to be prepared for an outbreak. So as a hospital, or as a group, we're owned by United Care Queensland. We actually have a crisis team for the whole of United Care Queensland, and within our groups we have healthcare, we have family and disabilities, community, and a lot of aged care. We've got 47 aged care residences. So a lot of what we're doing in our pandemic plans actually covers those. And obviously it's quite frightening what's happening around the world and in Victoria in aged care. We have our own pandemic plan, and we, in the first wave, we were in regular contact with SCU and with Naomi and her team, just to see how we could help and how we could support each other. And that's still ongoing, depending on what the next step is, if you like. We also contribute, like Karlyn said, with the district response, the disaster response groups, and that's important that we work together with them. So that's ongoing. As a hospital, we're still screening everyone that comes in. So we have thermal imaging that can check 15 people's temperatures as they walk in the door, and we're doing some screening as to whether they've been interstate or been in Brisbane. Obviously, lately the questions have changed a little bit. We'll continue to do that for the foreseeable future. We've limited visitors, which has had to be, and I think that's been quite hard for people, particularly maternity patients or maternity ladies. But we want to just keep that again in place for the moment, depending on what happens next. As a hospital, I've actually been at Buderim for about 14 months now. Came from Melbourne. I'm happy to say I'm up in the Sunshine Coast at this point. Because obviously in Melbourne it's quite a challenging situation. We've celebrated our 2-year anniversary of our emergency centres. So the emergency centre at Buderim is the only private centre in the Sunshine Coast. And to celebrate that, a couple of months ago, we opened our chest pain unit. So we've got a 6-bed unit adjacent to our emergency centre, and we have an evidence-based accelerated pathway for patients to come through our service, either for tests for echoes or CTs or stress tests of any sorts, and they've got access to FASM. So we've got fellows of the Australian College of Emergency Medicine on staff at all times, and we also have access to our cardiologists. So that has actually started to grow. Our emergency centre reduced in numbers over the period of the first wave, and I think that happened again at school as well. The emergency presentations dropped, but we're starting to get busy again. So we look forward to growing that service even more, particularly in the cardiac side. With the hospital itself, we've got a large mental health unit. which I'm sure is known in the community. It's a voluntary service or a voluntary inpatient service and outpatient service. That has been challenging over the time of the first wave and in the past few months for some of our patients. Some patients didn't want to come and participate in the classes. We had to reduce the numbers because of the room sizes that we could provide care to, but a lot of the doctors or psychiatrists made up for them with telehealth. So they've done a lot of mental health assessments, etc., and treatments via telehealth. And one thing, the future I think is going to change with how we do our programs. We've been in discussions with Medibank Private recently, and they're actually asking about, are we doing telehealth classes, so PTSD programs, eating disorders, etc., etc. So that's something we'll look at it. The hospital has been busy year on year. It has grown up until February, until the COVID-19 hit. But what we've seen is a return to normal activity from July onwards. So we're healthcare as usual, or business as usual as it can be called, with all our services for surgery, medical services, obstetrics, etc. We want to focus on our patient experience and improve that. We've changed who we use for our feedback from our patients, so we're going to do a deep dive into that. We also want to look at what we're doing from a marketing or a digital marketing perspective, and looking at new platforms to communicate better with GPs. Traditionally, we've held two like women's health days or men's health days a year and a mental health day, but now I think we'll end up going through Zoom like everyone else, or this go-to webinar. But we also want to improve what we have in our communication to our GPs about our services and support. And it's great to see the mental health hotline, if you like, for the public sector that will help GPs treat patients and refer to appropriately. With the planning for the future, if I look at planning for the future, this year was our 40th wedding, I was going to say, our 40th anniversary of the hospital. It was started to be built or opened in 1980. Unfortunately, we couldn't hold the gala ball that was planned. We're hoping to hold it in June of next year, but really depends on what happens. We've grown, started off 48 beds, it's now up to 194. Mental health, cath lab, emergency centres, got a variety of services, and we're very proud of it. As part of the looking at future growth and expansion, we know that it's predicted that the Sunshine Coast population will grow about 36% in the next 10 years. So we're actually now master planning. So we're looking at our master plan to expand our services and the actual facility itself. When you look at the site that it's on the side of a hill, you think we can't build, but there's a way to do it. So there's further expansion planned. And that, I think with the COVID, just to highlight what Naomi said at the beginning, we have to look after our staff and our staff's well-being. Everyone's tired, and this is where people can hurt themselves and injure themselves. From a patient perspective, we've recognised that some people come into our hospital deconditioned because they've been in their home for so long and not been able to get out. And we're finding that they're at risk of falls, etc. So we just have to be on top of things as we're bringing in our elderly patients into our hospital and make sure we're looking after them to the best of our ability. And that's probably just a quick update from me about Buderim.
Thanks very much for that, Karen. And we've now got time for our final speaker, who is Justin Greenwell, CEO of Ramsay Health. Thanks, Justin, for your update.
Thank you. I look forward to meeting many of you over the coming months, and thank you for the opportunity to provide an update across our hospitals. As you can see here, we cared for almost 55,000 patients across the 3 hospitals on the Sunshine Coast over the last 12 months, just finished June 30. And our emergency department at Noosa moves between around 18 to 20,000 presentations, and that's where we finished our numbers in ED at Noosa over the last 12 months. Thank you. We undertook almost 20,000 operations across our 3 facilities, and approaching 2,500 patients received their cardiac care in our cath labs at the Sunshine Coast University Private Hospital. As an update on our activity, thank you. We undertake a number of specialties across all of our sites, such as gastroenterology and orthopedics and medicine and urology, etc. Renal dialysis covers all 3 sites and is now run as one service under one of my executive team. Certainly our public-private work in Noosa, we're very proud of that. Our strengths at Nambour continue to be our rehabilitation service, medical and respiratory, and key specialties, surgical specialties as mentioned. We continue to grow, approaching our 7th birthday at Sunshine Coast University Private Hospital, and have grown again over the last 12 months and continue to focus on building that clinical capability. Such areas as our neurosurgery, our cardiology and our cardiothoracic program is now thriving. Thank you. Our patient satisfaction is really important. At the end of the year just completed, we're in the top quartile of our Net Promoter Score right across each of our facilities, as you can see there, ranging from 82 to 91 as a Net Promoter Score. So still lots of areas to work on, and certainly receive concerns and complaints that we deal with, but a really good base to continue to improve the experience and the service that we provide to our patients. Just a couple of comments, if I could, on our COVID points. Certainly our colleagues in hospitals in Victoria are really challenged and doing it tough. 4 Ramsay hospitals are caring for large numbers of COVID positive patients within their facilities. We are undertaking 50 shifts a day, running and staffing aged care facilities across Melbourne, and unfortunately transmission of COVID-19 across our healthcare workers as well. We specifically and talk frequently with our colleagues to understand how we can learn and prepare and to be ahead if it's needed on the Sunshine Coast. And our most recent is reaching out to our residential aged care facilities across the coast to ask and seek if they would like assistance as where we can, providing training. We've trained for 7 facilities so far around PPE, aseptic techniques, donning and doffing, for example, across the coast. And we'll continue to do that as we try to ensure that if needed, we're as best prepared as possible and help others to be so. We're also continuing to screen. We introduced on the next slide the screening app that complements the manual process that we have if someone does not have a smartphone. And you can see on the following slide the screenshots, if some of you may have experienced it, if you have come into Nambour, Noosa or our Sunshine Coast University Private Hospital, recording and screening key information about our patients, visitors, contractors, and of course continuing to screen temperature as well. One last thing on the COVID is just we are trialling at this moment a virtual waiting platform. So this technology is to help us assist in that social distancing and managing those waiting areas, such as our day of surgery admission centre, where there can be a large volume building up for operations, etc. So this technology, as you can see on the next slide, enables when we register a patient at our front desk that they are able to sit in a waiting area in the foyer, move outside and sit outside, maybe sit in the car, go for a walk around the hospital, and then be able to be messaged to be called back in a timely way back to the hospital in terms of their procedure. The flow-on effect also is that we're able to then message the next of kin, ensure they're not waiting for a long period of time at the pickup end of a patient's admission to our hospital, and ensure that they're communicated with in a timely way so that they're also not waiting in the hospital or waiting for extended periods of time as well. Just a couple of quick points around some of our technology that we're working with at the moment. Our Da Vinci program continues to grow. It's specifically in the urology space. We are trialling in for specifically orthopedics, the mini C-arm you can see in the top middle of the screen at the moment. Our neurosurgery work and program continues to grow, and our O-arm that you can see in the top left-hand corner of that picture continues to provide great images in our neurosurgery. And just this week we introduced the ROSA orthopedic robot to the coast for the first case for knee replacement, robotically assisted knee replacement, and it was on Tuesday this week that we undertook the first case, and further procedures are planned for this coming Monday as well. Just 2 slides on our clinical trials, where locally we've established a clinical trials unit, and it's run by Amanda Williams. You can see in the picture there, we're one of 14 Ramsay facilities with clinical trial units. And just to give you an update on the clinical trials underway on the next slide, we have opened 2 oncology trials for recruitment, both in bladder and breast cancer. The Resolve trial continues, which has been running in the renal dialysis area for some time, but is ongoing. And just this last week at our medical advisory committee, we approved the 3 additional oncology trials moving into the startup phase, going through ethics at the moment, expected to commence and open for recruitment in the 4th quarter of this year. We have also been assessed for another oncology trial and waiting to hear whether we have been selected or not, and in early discussions around respiratory related trials as well. I'll just finish off with a few key points about the 3 hospitals, just for a couple of more minutes, and then I'll be finished. We, at the beginning of this year, introduced our Ramsay Connect program. It was just pre-COVID, and that has been successful as it moved through COVID and in the current state that we're in, about both hospital and the home, as well as rehab options in the home to complement our inpatient services across Nambour and Noosa. Thank you. As Naomi mentioned, it's wonderful to continue our partnership with Naomi and the team in providing care for the Noosa community with the extension of our agreement and partnership together. Thank you. Our very important part of that service is serving the community with the emergency department in Noosa. And if I just focus on 2 things in Nambour, if you move 2 slides, you'll be able to just highlight the strong focus that we have at Nambour on our inpatient and outpatient rehabilitation service. And thank you. As mentioned, our rehab dialysis service is now run as one service across all 3 hospitals, where we undertake a significant volume of private renal dialysis service and public patients as well at Noosa. Just last week, we launched on the final slide for Nambour a pelvic health clinic. We have running that out of our consulting suites in our Nambour location, pelvic floor physiotherapy expert providing that service, and taking bookings now already underway with a specific focus on areas such as bowel and bladder incontinence at our site there. So just my last slides, just to highlight finally at the Sunshine Coast University Private Hospital, update on our recent milestone, 1 year post our commencement of our structural heart TAVI program, undertaking our 100th TAVI procedure within that 12-month period. And on the next slide, I just highlight certainly there's 93 cardiologists across Australia that are undertaking and able to undertake TAVI. It takes a whole team there, 2 of which are interventional cardiologists providing that service now on the Sunshine Coast. My final slide is just highlighting, you may have seen in June, our Channel 7, the report on Joe Giuseppe, the 90-year-old Yandina farmer, and you can see him with Peter Larson and Stuart Butley here and myself, just as Channel 7 were interviewing him in relation to his TAVI procedure. He was admitted on Friday and discharged on Saturday with a new aortic valve, and is really having a great improvement and doing well out there on his farm in Yandina. So our structural heart program is now looking at the possibility of the MitraClip procedure, and that would complete the components of a structural heart program with and certainly complement our cardiology service and our cardiothoracic service at the hospital. So thank you.
Thanks very much for that, Justin, and that's a wrap for the night. Anyone who asked questions, they will be answered and put on the LMA website, I believe. LMA website's active, and there's plans for further webinars for the rest of the year. Stay tuned. Thanks everybody for checking in tonight.
Thanks, Karlyn.
Thank you. Thank you all.
Thank you.
Thanks, Justin.
See ya.
Yeah, thanks. Thanks,
guys.
Naomi. Wonderful.
Good to see
Everybody
you all.
wonderful.
Bye.
Thank you to my team.
Thank
Bye.
you.
Bye.
Have a nice night.
You
Well done,
too.
guys.
Bye-bye. How do we get out of here?